Hi everyone. This is a video to just go over the clinical prevention concepts that we talked about at the beginning of Unit 3. It's been a little while, and since you'll have these some of the questions on this material during the Unit 3 exam, I wanted to at least review it with you a little bit. If you recall, the things we talked about in the beginning of Unit 3 were about clinical preventive services, things that we do to prevent diseases. And so we talked about screening tests and all sorts of ways to list and analyze screening tests to determine whether they're useful and to critically appraise a study about screening. Um, Most of this stuff starts, if you recall, with the diagnostic test critical appraisal, which is a part of this, but we won't necessarily go over again in this video. You should have enough of a background from the previous work that you had to be able to understand that. And that goes on to the other preventive services activities, the vaccination, chemoprophylaxis, behavior change counseling, just to cover the gamut of the preventive services. If you recall, we also talked about ways that you can categorize preventive services, and we'll go over that in a second. This review will cover the main points. Obviously, you should still study the objectives to get the complete list of things to know for the exam. So we're going to start with our clinical example with lung cancer. You can see in these slides, these are the most recent cancer statistics compiled in this journal, which is a great cancer journal, for lung cancer predominantly. And you can see in males, it's kind of declining since about 1985, 1990 in there, when smoking rate started to go down principally in men. Unfortunately, we saw about the time it started to go down in men, it started to go up in women, and we've seen an increase in a replacement of lung and bronchial cancer, um, gaining in prevalence over the colorectal cancer. So these are good slides to just sort of get a picture of what's going on with cancer these days. But so we'll use lung cancer as our example here when we think about prevention. So thinking about prevention of lung cancer, you first have to organize your general thinking about prevention of any disease. So there are two different ways that we've talked about how to do this. One is in the timing of prevention, the primary, secondary, and tertiary prevention. And if you remember, primary is where you're reducing the risk factors that lead to a certain disease. Secondary, you're trying to find it early and prevent it from going on to be symptomatic and to cause morbidity and mortality. And tertiary is where you try to prevent the complications of the disease. So as we think about lung cancer, primary prevention would be things like the risk factors for lung cancer would be, think about it for a second, smoking, asbestos exposure, these type of things. So primary prevention would be targeted at getting people to stop smoking and to understand their risk for asbestos, potentially. Secondary, this would be where screening happens. So screening is mostly secondary prevention, where you find it in an early asymptomatic state. People don't know that they're sick at all or have cancer. You find it before that happens. And tertiary would be once you have lung cancer, ways to prevent complications, and we'll get to examples of that. Remember, the type of prevention activities, so the actual things that we can do, include screening, behavioral risk factor counseling, vaccination, and chemoprophylaxis. So for lung cancer, to drill down a little bit on this one. So for behavioral risk factor counseling, what could we do? Well, we could do smoking and decreasing the risk factors for common lung cancer, as we talked about, smoking and asbestos exposure. And then these would be both primary prevention activities. Smoking cessation counseling is the one we can wrap our heads around a little bit better because physicians routinely counsel their patients, or should be routinely counseling their patients about smoking cessation. Occupational history is a little bit more subtle. Unfortunately, we don't emphasize that as much, but it's probably, it's definitely very important in preventive medicine. And so taking a occupational history might lead you to understand that the patient might be exposed to asbestos. And then you can counsel them there about ways to approach their workplace or to find ways to get help to avoid that asbestos exposure. Lung cancer vaccination, well, unfortunately, there's not really much to prevent the cancer itself, although there are trials ongoing for all sorts of cancer prevention vaccines. But instead, we might have a tertiary prevention element here, where if you have cancer and you're being treated with immunosuppressives, then it's an important thing to realize that pneumococcal disease, pneumococcal vaccination, would be an important part of tertiary prevention to prevent sepsis as a result of the treatment for cancer. So pneumococcal vaccination to reduce invasive pneumococcal disease would be sort of an example of tertiary prevention, and definitely worth thinking about. For chemoprophylaxis, none, to my knowledge, has been proven, and they keep trying to find a reason to recommend vitamin D. So maybe at some point somebody will figure out that prevents lung cancer. But remember, chemoprophylaxis is the act of taking something every single day to prevent disease. The traditional examples would be aspirin to prevent cardiovascular disease, maybe vitamin D to prevent falls in the elderly, for instance, which has been proven. These things are chemoprophylaxis. We don't have much for lung cancer yet. Screening is the one where all the news is in lung cancer these days. There's been significant work done in the past 20 to 30 years about chest X-rays, and the idea that getting a screening chest X-ray on a regular basis, especially in smokers, might do well to prevent lung cancer, to catch it early. Turns out that they don't do that well, probably because they're not that sensitive. Once a lung cancer shows up on a chest X-ray, the cat's sort of out of the bag. Chest CT screening has recently been found to work to prevent lung cancer, to catch lung cancer early. And the recommendation of the study that supported this, the National Lung Cancer Screening Trial, NLST, did lung cancer screening with chest CTs annually for high-risk smokers greater than the 30-pack year history of smoking. And that's been shown to not only reduce lung cancer, but actually reduce overall mortality, one of the first screening studies to ever show this. So if you remember, while we're talking about screening, we have to go through what I've called the frame criteria, the criteria for deciding whether it's useful to screen for something. First, there must be an adequate burden of disease. In other words, it ought to be an important disease to go after in terms of prevalence. And we saw from that earlier slide that indeed lung cancer is very prevalent and one of the leading causes of cancer mortality and morbidity in the country. So it's definitely, there is a burden of disease. Is there an early asymptomatic phase? Remember that diseases can have, there's the disease onset, the point at which disease is detectable by screening, the point at which disease usually makes it manifest by when you have symptoms. So this is screening and this is symptoms, and then death at some point. So this early asymptomatic phase is this piece, sorry about that, this part right here, where you could catch the tumor by screening. So lung cancer definitely has that. Often times tumors can begin in the chest and they can be unknown to the patient. And so this disease does have an early asymptomatic phase. The test has to be accurate. So a screening CT scan for lung cancer is, in fact, the sensitivity and specificity are reasonable. Specificity was the one that was the biggest trouble. CTs find all sorts of nodules and scars and other issues on chest CT that have been found to cause a lot of false positives. But they've done a lot of work, and radiologists have, in figuring out which of those are important to follow up and how to follow those up so that you reduce the overall false positive rate. It's still an issue, but it's something that they've worked on in lung cancer screening. The test needs to be acceptable to the patient. CT scan is relatively acceptable if done once a year. It's only an X-ray. You don't have to have contrast for the CT scan. It's not an invasive procedure at all. So in general, this meets the kind of acceptable to the patient criterion here. A therapy has to exist for lung cancer, and that's certainly true. There are several therapies, both radiation and chemotherapy, for lung cancer. And then these two questions are where the money's at, basically, with the substantive questions for whether to screen for lung cancer. Does detecting the disease early reduce morbidity and mortality from the cancer? And from the National Lung Screening Trial, we find that it not only reduces morbidity and mortality, but overall mortality. So that's a very helpful test, at least on the face of it. One of the remaining issues that we still continue to work on is whether or not the National Lung Screening Study actually only went on for 3 annual screenings. So people only got screened 3 times and then were followed for many years after that. The current recommendation from the U.S. Preventive Services Task Force is annually with no real stopping date. So that's one of the things that people are looking at very closely. Not only for cost effectiveness, does that many CT scans cost that much? Does it really work to do that many CT scans annually for the rest of their lives? And then you also, not only does the cost come into it, but the radiation exposure comes into it. So these are the things that we have to keep in mind, the frame criteria, as I've called them, for when we should be screening for a particular disease. So the best way to see if screening, and by this I mean a screening program, not just the test to be able to diagnose it, but the whole test and the treatment and the follow-up and everything else, to see if a screening program reduces morbidity and mortality. You study it, and you study it preferably with a randomized controlled trial of screening versus not screening. So you have the diagnostic test study, which are usually cohort studies, etc., to figure out if the test is accurate. But you need an RCT to prove that screening works, just like any other intervention. So remember that as a way to do that. Now, the problem is, not only are there issues with bias in the normal issues with bias in a randomized controlled trial, there are all these screening specific biases that we need to understand. So if we have a screened group and a not screened group, and we follow them over time, then we have to pay attention to what do we have, what are the validity criteria for a randomized control trial. We look at randomization, we look at blinding. Now, blinding is sometimes kind of hard to do in a screening trial because you might be doing CT scans, for instance. You could blind a CT scan, that wouldn't be that hard. It's hard to blind colonoscopies for colon cancer, these type of things. So blinding is one of these that often doesn't get done as well. Randomization, blinding, allocation, concealment, and dealing with withdrawals and follow-up problems. So these 4 criteria, plus all the power and all the other criteria we've talked about before, are important. But now we have to deal with things like these biases. Let's start with the bottom one. Selection bias is merely a way to get to actually. It's a bias that occurs when you make the individual groups more different than you mean to. In other words, more different than just the difference between screening and non-screening. This has both internal and external validity concerns. One, anybody that volunteers for a screening study is generally going to be a little bit more attuned to their health, if you will, than somebody that doesn't volunteer for a screening study. So if you don't do a randomized controlled trial, so this is not having done randomized controlled trials, you'll get a volunteer group, and you'll compare them with people that didn't volunteer. And that would obviously introduce some bias because these people are more likely to be attuned to their health than these people. So selection bias can creep in that way as a validity concern. But also, even if you do have an RCT, there's a generalizability concern because you have people who would volunteer for a study. And so that might bias your results in terms of external validity a little bit. Referral bias has to do with the fact that you want to test, testing prevention activities should happen where prevention occurs. So ideally, you do it in primary care. it's predominantly an external validity concern, but it can occasionally mess with the internal validity, especially when you don't have randomized controlled trials. Overdiagnosis, this generally isn't a problem in lung cancer, because what overdiagnosis bias is, you get if you call as a result of your screening program, you call a certain number of things cancer that don't have necessarily as bad a prognosis as the others. In other words, if you have a fairly benign prognosis neoplasia that's called cancer, but compared with bronchogenic carcinoma or small cell carcinoma, it's just not as virulent or as pathogenic as that. Then if you call that cancer, and remember you're finding those in the screened group only usually, because you're calling those as a result of the testing, whereas in this group you're not screening and waiting for them to present with symptoms. If you include the things that aren't cancer in the screen group's outcome, then anybody with cancer is going to look like they have a better life expectancy in this group than people that are diagnosed with cancer in this group. So the issue is you're overdiagnosing cancer in your screened group. The screened group will have a better overall prognosis, and so it'll look like screening works better than not screening for dealing with cancer. And so the way to fix this is to ensure that your diagnosis of cancer truly represents a similarly bad prognosis across all diagnoses of cancer, and to make sure you're not overcalling cancer. Length time bias has to do with the screening interval. So for lung cancer, the screening interval is every year. And again, this isn't really applicable to lung cancer. What you're trying to do is if there were if there were a short span lung cancer that happened, that came up and then killed somebody, very quickly, and you also had the normal sorts of lung cancer that people lived with, several years with, and did okay, or even while undergoing treatment, maybe not living all that long, but still longer than the screening interval. The issue is in the screened group, the screened group people are the only ones caught by this interval. You'll be finding a bunch of these people with a slower overall progression of disease. And some of these people won't, in fact, have death as the outcome. They'll get better. And you'll be missing all these people. Well, in the non-screened group, you're going to count these people and these people. So if you're looking at the two groups, you're going to find that the screened group looks like they have a better life expectancy, again, because you're oversampling, or you're only catching the less severe and longer time course diseases in the screened group. And then finally, lead time bias. Lead time bias is, if you remember our diagram of the onset of disease, disease detectable by screening, disease detected by symptoms, and then death down here at the end. The lead time is the time that you've actually this is a screening event here. In this case would be a chest CT for lung cancer or whatever. This is the lead time. And what you need to do is you need to make sure your study is long enough to account for the point at which people would have died from this disease on average. Why? Because if you cut the study here, for instance, and you only follow people for this amount of time in the screened group, this might be the unscreened group here, this is disease by symptoms, and they follow out to this amount of time. It might look like this amount of time is equal to this amount of time, and or somewhat less than, that this amount of time is somewhat less than this amount of time, and it might look like there's a better survival advantage in the screened group. But what you actually have to do is extend this out, extend the follow-up out beyond the point at which they would normally die, to understand if the earlier diagnosis actually helps reduce this, push this date of death out a little bit, or whether people are dying at the same time and you're just finding that they lived with disease longer because you found it by screening, not by waiting until symptoms. So that's what lead time bias is. Again, go over all these. There are plenty of examples in both the PowerPoint for the session and in the references I've given you. That's about it. Good luck on the exam, and certainly email me if you have any questions.